and let you jump off, Ryan.
Good morning, everybody. Welcome back to session 4 now of this harm reduction intensive training series. We always look forward to this spot in our week. It's great to be with you and have these discussions. Run us through some quick housekeeping. We got a lot to get to, and hopefully some good conversation, some actual dialogue as opposed to more didactic learning today. So, as always, we invite folks to be present with us. If you're able to kind of find the time and find the space to shut off your inbox, turn over your phone, just a gentle invitation there. Again, we continue to be able to offer CE credit. So for those folks that need licensed social worker CE credit, stay the whole time, participate in our discussions, respond to poll questions, and turn on your camera the whole time. That's actually an invitation for everybody, even if you don't need social work credit. We love seeing your faces, seeing you like frown at us when we say something weird or smile at us when we say something good. So for those folks that do need social work credit, the evaluation each week is asking for your like social work information, but we're not going to give that credit until the end of the series. So you'll get, 4 out of 6 hours or 6 out of 6 hours or whatever of CE credit. So don't worry that if you haven't received a certificate yet, we're going to do it all at the end. As usual, we encourage questions and comments throughout. So drop those things in the chat, privately message us if you're feeling shy about a particular question. But get your needs met as we go rather than holding your questions to the end. You can use the chat once again for that. Course evaluations are required, whether you need a certificate or if you just want to give us feedback. And again, we read all of that feedback even from week to week. And so we're kind of adjusting content on the fly or adjusting like direction on the fly. And so that's really important to us. So thanks all those folks that are providing feedback as we go. And then we do have the closed captioning enabled, so you can click it on for yourself if that's helpful. All right. So for our agenda today, we'll go through a quick review of some of last week's material. We'll talk about some specific harm reduction interventions that are relevant to drug use. And we've been having this broader conversation around risk. And so we do want to kind of have a more specific conversation around drug use at this point. We'll talk about some special considerations for opioid use in particular, and we'll talk about those critical high-risk transition points in people's lives that overdose is a particular risk. We'll talk through this idea of risk set and setting as a way of understanding risk and how we can help kind of manage risk with folks. And then we'll have time for Q&A. In terms of our learning objectives today, the kind of main one that we'll hit on today will be listing 3 harm reduction tools to engage with participants around risk behaviors, and in this case, in particular, drug use behavior. So, in terms of a review, we spent a lot of time talking about common myths about harm reduction last week, and also criticisms. And I won't pretend that those criticisms aren't valid or real. We do have responses to those things, but I just want to kind of list them here, right? So number 1, a person absolutely has to hit rock bottom in order to recover. And that is a part of many people's story, but we wanted to kind of highlight the idea that it's not a part of everybody's story, nor does it have to be, and that rock bottom can often be code for like, you got to suffer a little bit more before you're ready to make that move. And that's just not true for everybody. Another kind of common myth or criticism is that harm reduction actually encourages drug use or other risky behavior, makes space for it, wants it to happen. And that's not true either. And in fact, we see kind of the opposite, where many people are deciding to engage with treatment options or alter their relationship with substances as a result of harm reduction interventions. That harm reduction sends mixed messages. Like, we want people to be safe, but we're actually like encouraging greater drug use, or that that we don't actually care about people's health and well-being if we're not attempting to kind of like force them to alter their relationship to substances. This other kind of similar one, that harm reduction fails to get people off substances, right? So it doesn't end up doing the job of inviting abstinence ultimately, or inspiring any kind of behavior change. And of course, we mentioned that like that's not our goal with harm reduction, right? The goal isn't abstinence, although for some people, it is a spot on the continuum that they'll reach. Another one, people are abusing the system and the availability of Narcan because they're getting overdoses reversed very frequently. And so we talked about the way that Narcan is doing its job when it's reversing overdoses, and that nobody among us should really have the power or ability to decide now it's too many times, right? So let's continue to allow people to be alive so that we can help them in the future. And then this last kind of common refrain, I can't help somebody who doesn't want to help themselves. And so we talked about the ways that sometimes we need somebody who's willing to go the extra mile for us, all of us. But that also, it's not really clear or visible easily to us when change is happening. Change is a somewhat invisible internal process. And so we don't want to kind of end before the miracle, as they sometimes say in the rooms, right? So keeping the options open, keeping things moving forward. And we did talk a little bit about the way that actually we think that there are some similarities between a more traditional 12-step way of approaching substance use and a harm reduction approach, right? Where abstinence only approaches do tend to limit choice and self-determination a bit, especially thinking through like DNA programs, right? It's like, you got to do it this way. There are a set of rules and a set of requirements in programs that enforce a certain way of being that limits choice and self-determination. Whereas on the flip side, harm reduction tends to kind of move in the direction of greater levels of autonomy and greater levels of safety. But there are some commonalities that we pointed out last time, right? Both of them are interested in meeting people where they are. Show up as you are, and let's find something that works, right? The crucial and critical element of peer support. And we talked about earlier in the ways that harm reduction is not forwarded by social workers, right? It wasn't created by social workers. It was created by people who wanted and needed to help themselves. And then similarly, the kind of self-help NAAA style 12-step groups are really kind of each one teach one, very similar, right? Like contributing and collaborating together. And then this idea that any positive change is worth celebrating is critical to harm reduction. And we see that kind of principle show up in 12-step recovery also. So that's a quick review. We want to kind of dive in now about drugs in particular.
Ryan, I did want to stop and just like let folks kind of reflect or respond. Any questions that have come up since last week, maybe flip to the last slide before we charge ahead. Just curious what folks have been sitting with, what's been on your mind, if any of this has brought up any questions for you. We're going to ask y'all to talk a lot today, so you better start guzzling that coffee now. All right. Well, it looks like we did an excellent job. Everyone understands everything perfectly, so we'll just move on.
Perfect. Job well done. So sometimes the risk that we're talking about, the potential harms that we're talking about, are in the drug type space, right? Like that's really what we're talking about. And so we've had so much conversation around broadening the conversation around risk, but let's narrow back down a little bit and talk specifically about drugs today. And so we want to drop a quick poll for you, and sort of see like around specific harm reduction interventions, what are your particular attitudes and thoughts, right? So let me launch this poll. And we're asking about Narcan and naloxone. We're asking about syringe exchange. We're asking about the use of medication-assisted treatment, or a medication for opioid use disorder would be another way of talking about that. So things like buprenorphine, methadone. And then we're also asking about safe injection or consumption sites. So that that poll is running now. Give us a sense of your feelings about these particular interventions. We're at about 75% or so. So we'll give another couple seconds here, maybe 10, 15 seconds. All right, let me go ahead and end this poll. Thanks for responding to that. Let me share the results. Everybody's saying, yes, I'm into this for every single one. Not a lot of dissent here. I wonder if people can say a reason, maybe why. Like it seems like people are feeling pretty strongly about these interventions. And I wonder if there were particular arguments that swayed you in the past that you've heard or through this series, or have a particular like professional experience or personal experience that have said to you like, yes, we need this because of X, right? So let me just stop talking there and sort of see like, what, why? Why do you support these so strongly? When I would say that like the general public does not support these interventions quite so unanimously. Oh, Jamie, stop it. You're just hitting us right in the trainer feels. They all promote safety and autonomy. Absolutely. If harm reduction is about promoting safety and bodily autonomy, and those are values that you hold true for yourself or hold carefully, I kind of agree with you. Like these ones are ones that potentially do support those things. And so it's like, yeah, it aligns well. Other folks, what are you thinking? Why? Why in particular? And then we also have one person who says they're maybe a little unsure about the use of medication for opioid use disorder, right? And so I'd love to hear a little bit about that. Why? And this is really kind of a judgment-free space, right? We're here to learn, we're here to grow. So we just want to kind of hear how you've come to these opinions and attitudes.
Sorry, y'all. Talking's gonna be mandatory today. We'll start calling on you if we have to. Molly, you're gonna be the one that's called on first because you're the only one with the camera on too.
Sure. So I would speak a little bit to medication assistance piece. So I spent time working in an OBAC clinic for a while, and I think one of the things, it's a good tool for engagement. So I am a social worker, and I always like that this helped bridge connection between like medical, mental health, all this stuff, and it just opens up the door to a lot of other resources. But also I think even for people who might struggle with the ambiguity of harm reduction, MAT in particular, it's data driven. So there's research, there's science that shows this is how it works, this is how it helps you. So I think even for the skeptic, you can look at this and say, here's something concrete that you can wrap your head around and see the positive impact of what this does.
I like that perspective, especially kind of like speaking to an audience that is like not sold, right? You're kind of like forwarding a little bit the medical model of stuff, right? In a way that people are just like so accustomed to believing in. Doctors are doing it, doctors are prescribing it, it like must be a good thing. That they're kind of speaking to that. It's an appeal to authority, I guess, to folks, right?
A little bit, yeah.
Yeah, but I agree, like this way, like programs that offer things like this tend to be programs that offer a bunch of resources too, right? And so people come for their Suboxone or whatever, and they leave with a referral to X, Y, and Z. And so it's sort of, it's a center point where we can help people meet a lot of other needs. Great point.
I also always like that it connects people to group settings. So I always found those to be like even more than individual counseling, connecting to peers and having that kind of support. Those are always the engagement strategies that we used in the programs that I worked in, and I found those to be more helpful.
Nice. That's a great point. Yeah, that's the only one of these that I can see that like definitely mostly like are very inclusive of group and peer connection in particular, like as a part of the main model. Yeah, nice one.
I think that on that note, though, I think MAT and MOUD are like inherently harm reduction strategies, right? We are using these to combat addiction, right? Cravings, physical urges, and like the physiological stuff. I think what I've taken issue with in the field occasionally is that eligibility and adherence to these programs does kind of strip away some autonomy, right? Like group therapy is great, right? But does somebody have to go to group therapy to engage in methadone maintenance is a model I've seen here in Philadelphia. Is you are not medicated until after you've engaged in this group session, right? You're medicated during the break, then you come back for the rest of the group, and then you leave. I think that's where I find it a little hard to grapple with. So while, yes, I definitely support this for folks who find this helpful, I can also see why it might also chase some others away. And then I also think the IOP model is really harmful. And I think a lot of these are provided in the IOP space, right? And we don't necessarily take into account all the time that it takes to engage in 3 hours of therapy 3 days a week, right? That's 9 hours. People aren't working or need to call out of work or need to like engage with their employer's EAP if they have one, right? And our the quality of life in other areas may start to kind of decrease when these additional kind of treatment requirements are coming into play here.
I love your points there, Khalil, and especially this idea that like an intervention isn't inherently autonomy promoting or safety promoting. There's also additional work to kind of like make sure that it is, right? Like we're providing this, and we've seen like here at Pathways, this model around, I've definitely worked at places where if Suboxone is not in your system and other opioids are, they like, like you're kicked out of the program after a certain period of time, right? Like they're taking urines very frequently. And we've seen here like a different type of approach. Our kind of medical professionals are risk tolerant and also are like people are going to be less likely to overdose and more likely to be on it if we keep prescribing it. And so we know they're selling it, but like maybe that's okay. And so it kind of matters how you implement these interventions using kind of harm reduction principles. Great. Thanks so much for contributing kind of just thoughts there. I'll stop sharing the poll. But people are sold on harm reduction. Love to hear that. I want to talk quickly about values, bias, and identity. So lots of behaviors that people engage in are stigmatized. We've talked about that quite a bit through this series, right? But behaviors by certain individuals or certain groups are even more stigmatized, right? And so when we're thinking about specific risk behaviors or specific drug use, our own values and biases do play a role. And so if you're a person, I find it impressive, people like Andrew, that like, you've heard him say that he is a harm reductionist by day and a 12-stepper by night. And like how to kind of navigate that is a critical piece of this, right? If you're a person that sort of really buys into this idea that like, I can't work harder than my client, maybe does it matter like who the client is? Are we more willing to reach that hand across and support certain people with certain identities? Is that unconscious? Is it conscious? And so there's a lot of self-work to do to kind of untangle our biases from like what we're doing and whose autonomy we're supporting. And so thinking about the intersection of racism and classism, sexism, transphobia, HIV stigma, fat phobia, all these other forms of discrimination, there are folks who face greater stigma out in the world, also in our policies, right? I think that's a place where stigma arises, not just from like the individual practitioner, but like us as an organization. And it's easy to say, oh, well, that's just the policy, right? Like that's just how we do it. But if it's having a disproportionate effect on certain people, that policy, then it is informed by, by a discrimination and stigma. So those are some things to consider as we're thinking about our own attitudes towards specific harm reduction strategies, right? And we see like these wrestling matches in the media around safe consumption sites or safe injection facilities, right? And like what neighborhoods are they going to go into, and who's going to use them, and like what's it going to do to the neighborhood for it to be there, and it's like who's forwarding these messages, and through what lens are those messages being forwarded? I think is critical for us to pay attention to as we evaluate our own attitudes toward harm reduction intervention, specific ones for drug users. Thinking also about kind of more moral and religious views and how that contributes to stigma around things like sex work, right? It's thinking about sex work as labor, right? And as like a low wage job in many cases. Do we kind of give the same scrutiny to abuses and low wages related to agricultural work, domestic work? Or are we really does it really hit us in the pearls that we must clutch when it's sex work involved, right? So all of these things are important to sort of be cognizant of and mindful of, because these things inform our specific interactions with clients. They inform our organization's responses to a given risk behavior or drug use in particular. So kind of just being mindful of those things is our main message.
Thanks, Ryan. I'm going to move us into talking about some specific harm reduction interventions for substance use with participants. So some of the kind of like easy to swallow or easier to swallow, kind of the gentle onboarding ramp into harm reduction for folks is some of the things we see here, like nicotine replacement is a form of harm reduction, like smoking cessation classes, or Chantix, or the patch, or all of these ways that we get people away from cigarettes. It's a pretty simple form of harm reduction for substance use for nicotine, right? We've talked a little bit about overdose education and safety planning. Next week, we'll share with you our personal safety plan that we work on with folks that can address a range of risk behaviors. We can talk a little bit more specifically about overdose personal safety plans, but having these conversations regularly and repeatedly with folks, making sure that folks have access to Narcan and naloxone. They know how to use it, even if they're not someone who is using opioids, right? But they might encounter other people in their community who are using opioids. Certainly, we've seen the pervasiveness of fentanyl and all kinds of other drugs beyond opioids these days. So teaching everyone how to recognize and reverse an overdose and doing safety planning around overdose prevention is a really good idea. We sometimes talk about money management as a form of harm reduction. Next week, we'll also talk about the honest budget, which is a tool that we use to help people track all of the ways that they make money and all of the ways that they spend money, encouraging folks to be really honest and straightforward about what those ways and means look like, right? That helps folks make more informed decisions about how they want to spend their funds. It helps us make sure that folks have enough money to get through the month and be able to eat while also meeting their needs around perhaps substance use or other ways that they spend their money, right? Medication-assisted treatment or medication for opioid use disorder, pretty common these days. We have an integrated healthcare clinic on site where we offer low barrier MOUD. We do Suboxone, Subutex, the Sublocade, injectable long-lasting Suboxone, and certainly we can refer folks to methadone programs if that's something they're interested in. Vivitrol, all kinds of MAT options on site. We encourage, folks who are kind of working in this field in supportive housing who don't have those services on site to find partnerships in your community where you can connect folks for those services, and the individuals that they'll be working with are harm reduction oriented, they're person centered, they're trauma informed, that they hold the same values that you have at your organization. Because certainly if you have a harm reduction orientation and you refer somebody out to someone who is going to be stigmatizing and harmful to them, you've then damaged your relationship with that participant as well. And then lastly, education on Good Samaritan laws, I think, is super important. So these laws vary from state to state, but generally provide immunity from arrest, charge, or prosecution for certain controlled substance possession and paraphernalia offenses when a person is experiencing an opioid-related overdose, or if someone observes one and calls 911 for assistance to seek medical attention. So our laws in Pennsylvania grant immunity from charges for possession of a controlled substance, along with 31 other states and DC. Paraphernalia is protected, or immunity from prosecution for paraphernalia is protected in 20 states and DC. In Massachusetts, your Good Samaritan law provides protection from drug possession charges when an overdose victim or an overdose witness seeks medical attention. But the legislation does not protect individuals from being prosecuted for other offenses, such as drug trafficking or weapons charges. It also doesn't protect individuals with outstanding warrants, nor would it interfere with law enforcement protocols to secure the scene of an overdose. So important things for you as a provider to know so that you can share that information with the folks with whom you're working. I think where we start to get in the weeds a little bit and having more challenging conversations around harm reduction, some of the things that we've seen providers push back against or have a harder time adopting are ideas around educating people on how to use safer, right? So having conversations on what factors might impact somebody's substance use and modifying your practices to kind of mitigate some of the potential drug-related harm, right? So considering where you use, who you're using with, what you're using, how much you use, where you got your drugs, any current health conditions or medications, assessing your mood, having a plan for emergency, et cetera. Ryan's going to talk to us in a few slides about the risk setting model to get more into that. Sometimes we also talk with our participants about switching from a higher risk substance to a lower risk substance, right? Some research has shown that marijuana can be helpful in getting people off of opioids. We've also worked with folks, I can think of one participant in particular who really needed a hip replacement, and she was using a lot of cocaine. Her doctor said, "I don't feel comfortable putting you under general anesthesia with cocaine in your system. Can you just switch to smoking weed for a little while? I can give you anesthesia and do a hip replacement with weed in your system, but not cocaine," right? And so sometimes that temporary intervention around harm reduction to get somebody's, like a health need met or another immediate acute need met. Sometimes we'll talk about switching the method of delivery. Certainly it's going to be safer for somebody to snort a substance rather to inject it. Syringe exchange, safer smoking kits. We partner with Prevention Point Philadelphia to meet some of those needs. I'm not sure what the syringe exchange or syringe services programs look like in the Boston area, but helping folks get connected to those services, acknowledging the reality that folks are going to use, right? And we might as well provide them with the tools in order to do that safely. Research has shown us that syringe exchange has a major impact on reducing the risk of contracting HIV and hepatitis C. It minimizes suffering for folks. It helps keep people alive long enough to consider maybe making some changes in their relationship to substance use. I know the Philadelphia Department of Public Health recorded a 34% decrease in new HIV infections among IV drug users following the introduction of our harm reduction and syringe services programs in the city. What's up, Khalil?
I just wanted to mention that one of the additional services that our syringe exchange offers here in Philadelphia is a women's night for women who, or for folks who do engage in sex work at all. they can like just talk in like a group setting, but also like take showers, take care of like hygiene. I'm gonna have access to things that make sex work also a little safer, right? So condoms also, when we're talking about harm reduction, is probably an easier to swallow. We know what they're for. We know that they're super preventative and that people are going to have sex anyway. I think is another good example of a pretty understandable harm reduction tool. But yeah, women's night. I think they've also moved to having a men's night also, which is pretty awesome too, because it's pretty open door. People are coming in, taking showers, getting resources and whatnot too, right at the syringe exchange too, which sometimes opens that door if people don't know that that's what goes on there.
Awesome. Thanks for adding that. Supervised consumption sites, supervised injection sites, or safe injection facilities, overdose prevention centers, lots of different names for these sites. Certainly a very controversial topic for a lot of folks. The United States opened its first supervised consumption site in New York City in December of 2021. In their first year, they reversed 603 overdoses and recorded no deaths on site. So we know from international work that these sites are very helpful in preventing overdose, saving people's lives, and getting folks connected to much needed services. The Don't Use Alone hotline is also a great resource if folks are not familiar with it. It's a 1-800 number that anybody can call. An operator will take some basic information about where a person is located, stay on the line with them while they use, and if the individual stops responding at a certain point in time, the operator can then alert emergency services to that person's location. It can be done via chat as well if somebody doesn't want to actually talk on the phone, but they have also reported, being able to intervene on, hundreds, if not thousands of overdoses. So that's available to folks everywhere as well. Thinking about harm reduction specifically for opioid use, and Khalil, feel free to jump in and talk about any of this in your more recent experience on our clinical teams, but certainly providing fentanyl testing strips to folks who use opioids, but now seeing that fentanyl has kind of gotten into the supply of many other substances, I think providing fentanyl testing strips to as many people as possible is best practice. Sometimes, and again, these are conversations that are maybe can be a little more challenging for folks, but talking about slow push, staggered use. So staggered use, right? Not everybody getting high at the exact same moment, taking turns, right? So that we watch and make sure that this person's not going to overdose before this person uses, right? A slow push is exactly what it sounds like, encouraging folks to inject very slowly so they can start to feel the effect of the drugs before they have used the entire shot. This can sometimes help prevent overdose as well. In addition to providing Narcan or naloxone to folks in our programs, making sure that we have signage all over our building. I have a button that I put on my backpack that says, I carry Narcan, right? We have signs all over office doors saying there's Narcan in this room, there's Narcan in this room. We also want to provide folks with sharps containers and ways to dispose of syringes or paraphernalia safely. We have those both in our office building, and we provide them to folks and can swap out when one is full, give them a new one, and so that folks are, disposing of things safely. We've also, in the past couple of years, installed reverse motion detection overdose monitors in all of our bathrooms on site that our participants have access to. So the way those work is when somebody is in that bathroom, you close the door, a timer starts. I believe it's if it detects no motion for 2 or 3 minutes, a very loud alarm will go off that anybody on that floor of the building can hear. We have a protocol for how to respond to that. There's an overdose reversal kit with CPR supplies and gloves and masks and Narcan, along with a master key that will open up that bathroom located near each of those restrooms where there's an overdose monitor. I know of at least one instance in which we were able to reverse an overdose because of those alerts. So they were quite costly to install, but paid for themselves very quickly. Khalil, I saw you unmuting to jump in, so please, anything you have to add?
Just off the back of this overdose monitor idea, Pathways is also moving toward, and this is like a long-term thing, but some smart home technology, right? Like technology in folks' home, not surveillance, right? We're not watching our folks, but things that can detect like fires and floods, right? Because when our participants fall asleep and maybe they had overdosed and we're cooking or like we're running water, these are other signs of an overdose that we can't see, right? Because we're not with our participants 24/7 in their home. So this is something that they're trying out with 2 units in the future. And these are kind of going to be temporary units for folks who are like recently released from incarceration. We'll talk about some of these later too, like what makes someone a little more high risk, those transition points, but discharges, they might stay in those units. Yeah, that's something that that's on the radar, and I think is pretty cool.
Not sure what's going on with our slides there.
I thought
Okay.
that was my cue to stop talking. So
It was not. The slides went a little wild for a second. But you have the floor if you want to talk a little bit about some of our risk for overdose. There we go.
Yeah. So folks doing this work, like you already know, our folks tend to use over feelings, right? When there are big feelings involved, somebody is more likely to use, or maybe more likely to use more than they do on a regular basis. When there are major life events, I think a family conflict is a big one I've experienced on the team. Oh, my brother did this, or they used to treat me so nice and we're fine with my use, and now it's this. And kind of that isolation from our family members has, I think, been a significant trigger for folks recently. This could be like the holiday time has, come and gone, and that brings up big feelings for folks too. Death and dying, grief and loss, when people lose loved ones and also have this added piece of their addiction, what they feel like that has done to their relationship too, I think also contributes to big feelings and increased use. Traumatic events, of course, people experience hard things when they are street homeless, right? And we know that those things don't go away when they're housed necessarily, right? It is definitely a learning curve and a lot to learn and adjust to. And then we have some informal transitions. In trauma-informed care, we talk a lot about how like avoiding surprises as much as we can is best practice, right? So I'm sure it's also easy to imagine that when folks have abrupt transitions in their lives, right, or ones that they weren't able to prepare for or had on their radar, that this can also be another item that can increase their use of risk over feeling. So I think to really understand this slide and understand when someone might use over feelings, is to think about you and your own life and your own feelings. Like, what do I do that's negative coping? And it might not be substance use, right? We may not engage in substance use, but we have other like negative coping mechanisms, right? Are we isolating? Are we shutting in, right? Do we like engage in like some self-deprecating talk, right? What are we doing? And then flipping that over to the participant. Wow, this participant is experiencing this hard thing and big feelings, and I know that they use substances regularly. I should go check on them, or I should check in with them about this week.
So I think on the flip side of that, right, a lot of the reasons that we see folks potentially using more are related to these kind of generally perceived like negative life events, right? There's also some positive things that happen for folks that can be challenging as well. So high risk transition points, we consider any transition where somebody goes from being relatively like surrounded by other people to being mostly alone or isolated. So thinking about when somebody is moving from the street or moving from a congregate shelter into their own apartment for the first time, right? Maybe in an encampment, they're surrounded by other people. In a shelter, they're surrounded by other people. If you're sleeping in a park, there is a relative amount of foot traffic in the area. And then once you're in your unit, you're there by yourself, right? When folks are discharged from the hospital, similar, right? You're in a supervised site of some kind where there are people around. You've returned to your unit where you're relatively isolated. Same for when folks are being discharged from incarceration, when they're returning to the community, and when folks are coming home from inpatient substance use treatment. All of these things are positive changes, right? These are all things we want folks to be in their own units. We don't want folks to be hospitalized, incarcerated, or in treatment forever. It's a good thing when someone returns to the home, but these changes still come with danger and risk, right? So some of the strategies we use to mitigate risk in these specific settings, right? When somebody first moves into their apartment, obviously, making sure they have access to Narcan, as much Narcan and naloxone, fentanyl testing strips, sharps containers, et cetera, right? But a big piece is also increasing possibilities for connection, right? Making sure folks know where they can go outside of their house to get connected to local resources. Making sure they know where their local food pantry is, where their local syringe services program is, right? And really increasing our efforts around community inclusion. How can we get folks to engage with us so that they're not isolated in their unit all the time? So doing all of that overdose safety planning and education, but these other resources to get folks back into the community and around other people is a great idea as well. When we think about discharges from the hospital, again, making sure that folks have Narcan, have naloxone, we're having a realistic, honest, straightforward conversation about their increased risk for overdose. When there's been a period of abstinence while someone has been in the hospital, right? We know that their tolerance is lower, and we want to make sure that folks understand that they can't go back out and use the same amount they were using before they went into the hospital, because they're going to be much more likely to overdose. We found for hospital discharges that pairing a registered nurse on our teams with one of our certified peer specialists can be a really great combo to facilitate some of these discussions around what does your medical aftercare look like, and what does your kind of safety plan around substance use look like as you return home. Similarly, with discharge from incarceration, one thing that we want to provide, if we can, is transportation back to somebody's unit. A lot of times, the jails in Philadelphia will put somebody out at 11 o'clock at night, with like a bus token and say, good luck getting home. We often don't know what time somebody is going to be released. If there's a possibility, we can park a staff member in the parking lot with like a pizza and a book, to wait for somebody to get out so that we can drive them home and make sure that they have Narcan, that they've had a conversation about their increased risk for overdose. We want to do that whenever possible, right? And of course, providing that low barrier access to MOUD, initiating that as quickly as possible if folks are interested. If we can pick somebody up and bring them right into the office for an induction, that's fantastic, best case scenario. And then discharge from inpatient substance treatment, again, transportation from one of our trusted team members is ideal, right? Ideally, our team should be collaborating with the substance use treatment program to facilitate that discharge and make sure that somebody gets home safely, that they have, an aftercare plan in place. Again, providing Narcan, having that conversation on, an increased risk for overdose. Obviously, the ideal for a lot of folks leaving inpatient substance use treatment is that they're not going to use again. But realistically, we know that folks often return to use. So we want to be honest and straightforward about that increased risk for overdose. Again, involving our substance use specialists and or our certified peer specialists can be really helpful in this area. And then a lot of times we can collaborate with inpatient programs to initiate somebody on MOUD before they're released and returned to the community. Anything that you have to add here, Khalil?
Not a ton. I think this is great and super thorough. I think that the conversation piece with the participant is really important. And the way we did it on our team is I didn't want folks to say like, you're at increased use of overdose, right? I wanted them to let participants know, and it's not a scare tactic, but like super realistic, right? That you're at an increased risk of overdose death, right? And here's what we need to do to make sure like you are safe. And this is also the language that we use when we talk to providers, right? Who are going to discharge somebody without a plan, right? Or they don't have a unit, but we have a unit for them in 2 days. We say, hey, this person is at increased risk of overdose death. And like, if we could have them stay here for 2 more days, like that likelihood is like significantly decreased, right? Because they will be in a home, we know where they are, we can check on them. Yeah, so I think the language that we're talking about it with folks, the participants and other service providers is also can be considered an overdose prevention strategy for sure.
Awesome, thanks for that. So the last kind of piece of information or strategy we're going to offer today is this tool that you can use around conversation for reducing risk with folks. It's our risk setting. I'm going to toss it over to Ryan for that, and then after that we'll take some questions before we end.
Yeah, Andrew, mentioned that it is a tool that we can use, and I'll just emphasize that it's a tool for us as providers, as we're kind of strategizing, as we're thinking of, what strategy makes the most sense here, or when do I need to use an overdose prevention strategy. It's also a tool for our participants, right? We want them to sort of like be able to think through these core elements of a given risk so that they can kind of autonomously make decisions that are in the best interest of their own safety, right? So it's offering us more tools all around. So you've probably seen this. It's a very commonly used tool in harm reduction conversations. It's risk setting. And so risk is kind of the literal risk itself. Is it drug use that we're talking about? Is it sex work? Anything that's influencing housing tenancy or stability, right? In the housing first type context, right? And so what is the issue that's being presented? How much of the drug, what's the drug? How much are they using? What is the method of intake, right? Like, how is it coming into the body? These things all influence the risk. Are there other kind of sources of harm that are connected to that main issue? I'm thinking about like chronic illness also, that a person may have or be dealing with, and then they're also engaging in this risk behavior. Do those things influence one another? Kind of important to sort of think about this in a broad way. What is the risk of overdose, right? Has this person overdosed before? That all kind of plays into this conversation of what is the risk. And that also gives us some levers to pull on, right? In terms of influencing risk. So you're using in this way or this method of intake. Had you ever considered this other method of intake, or is there room for kind of a temporary alteration while you get through moments of big feelings, as Kalo mentioned, right? Is that a place where we can alter? How frequently are you using? And again, how much? Set is kind of where people are showing up to drug use behavior. What's their mindset as they show up to this, right? And so, again, as Kalo mentioned, like, we all sort of have ways that we cope with challenges or difficulty or emotional experiences. And so what is it when I'm really anxious? Is that when I use most? Or is it when I'm really upset? Or I'm going to go really hard when I'm, angry at, interpersonal interactions? Kind of helping people explore and understand where they're at, like kind of emotionally, what's their mindset as they engage in risk behavior. Is an important component of this, right? Thoughts, moods, expectations. What do they expect that they're going to get out of this? As we're having conversation with people, are they able to engage with us fully, right? Are they in a place where they're able to kind of have a dialogue with us, or do they need rest? Are folks physically in pain, and that's contributing to like how they feel? Do they need to get well? Are their basic needs being met, right? Like, all of that contributes to the mindset that people show up in. And the more uncomfortable we are, the less kind of at our baseline, thinking clearly, the riskier a given behavior might be, right? And so using this set as a way to kind of, as a lever that we can tug on, can we help people develop some internal coping strategies or some external coping strategies that can alter mindset a little bit, so that when I engage in this drug use, for example, I can make it that much more safe, right? So that I'm not kind of at the edge of my emotional tolerance and I'm just barely above water. And I can actually focus more on being careful and doing this in the way that I want to do it, right? And then the last one is setting, right? So this is the physical and social environment where drug use might be occurring. Is somebody using in a home? Are they in a workplace? Are they on the street? You know, who are typically around? Are there like supporters around? Am I kind of just popping off like, I don't know, on a park bench? Are there typically like police around or bystanders? How do I present to people out in the world, right? Am I seen as like, am I perceived as a drug user, right? Am I perceived as somebody that is frequently stigmatized? How might people around react when they see this go down, right? These are all things that we can influence and inform our potential strategies that we use when we're brainstorming harm reduction interventions, right? So risk set and setting are a set of things, a set of buttons that we can push in collaboration with a participant, places where we can generate some brainstorming based on what is the answer to some of those questions. And that brainstorming hopefully are things that allow for a high level of autonomy and choice, but also help people move towards greater safety. So I'll stop there. Any questions specifically about risk setting before we kind of open it to a broader set of questions and comments? Cool. No worries. All right. So we talked about a lot of different strategies today, and that was our goal, right? Like that was our learning objective, is to list at least 3 kind of specific strategies to reduce risk. And so I think we've done that pretty good, specifically around drug use. And then this last one, risk setting, I think can be applied more broadly. So are there any questions or comments or thoughts or discussion points that people are sitting with right now as we wrap up today?
That can be things we've talked about today or previous weeks, or not at all, but are kind of related to the theme of harm reduction, whatever y'all are interested in. Layla, I saw you on mute. Layla went back on mute as soon as I unmuted.
They unmuted again and muted again.
Oh, mic isn't working.
Got it.
Feel free to type whatever you got in the chat.
Looks like David turned his camera on also.
Feel free to jump in. As we're waiting for Layla's comment in the chat, I do want to ask folks, thinking about, we talked about some of kind of those easier onboarding into harm reduction kind of strategies around providing Narcan, providing, oh, Ryan, I was trying to share a slide.
Zoom is going wild.
Let's see what Layla has here. We're discussing how to integrate use of 2 milligram Narcan, and I'm just generally curious about thoughts, experience with that. Khalil, do you have any knowledge on that?
Is 2 milligrams like half a pump or like an actual smaller dose? I know that in the streets, participants sometimes will say, oh, this person doesn't need like a full thing of Narcan. And very early in my experience, I tried to give someone like a half a pump of Narcan, and I wasn't super successful. I don't know like how to measure that, or if that should even be a thing right now, unless they are like actually like administering them in like smaller doses. Yeah, it's hard. So I think, yes, there's experience, but I think it's also like experimental. And like if somebody is overdosing from something that's not heroin, like fentanyl, it decreasing I don't think is a good idea. Because sometimes Narcan and like multiple full doses of Narcan aren't helpful in bringing somebody back. So I think I would err on the side of caution. I would believe that precipitated like forced withdrawal sucks, and people are cranky, they're upset, and they're mad about it, right? But they're also alive, right? So I think erring on the side of alive versus like half a pump, but they're not alive, might be the better route to go here, if that's the reason for 2 milligrams, 2 milliliters. And then another thing I'm thinking about is, so xylazine is really big here in Philadelphia. I don't know what it looks like elsewhere right now. But this is not an opioid, and Narcan is not effective here also. So there are some smaller organizations right now who are working on, hey, here's what we do to address a xylazine overdose, because it looks very similar, but also has some very small differences, right? Where if you're Narcanning someone, it can be very alarming if they're not kind of coming to, because the overdose was not to an opioid at all. That doesn't answer that question directly, but it's just something that this made me think of.
Yeah, thank you for that, Chloe. I was realizing that that was an oversight that we didn't have a slide on that.
Can you hear me now?
Yeah,
Oh, thank God. Sorry about that. It's just too much to type. So the 2 milligram I'm talking about is the one that comes as a 2 milligram. Actually, we have EMT techs who are here with us during the night, and they haven't used a 4 milligram in 3 months. And so they're discussing, it's the one that, I don't know if that's working, but it's the little one that you put together. And so they want us to, we're kind of talking behind the scenes on how to get people trained on that, because I mean, it's hard enough to get people to use 4 milligram Narcan. So this is kind of like a different fight. I think their argument is that it doesn't send people into withdrawal. They don't come back as violently. And they just haven't found it necessary. I mean, we're having the same deal with xylazine, that people are just knocked out and taking forever to come back. So they're kind of talking about I don't know, trying to figure out how to make this like a pilot program, because we really only have anecdotal data so far that you don't need the 4. Like if people are, they've been reviving people for months successfully on 2. So why put someone through that if it's not needed? And so we're just kind of starting to have these conversations and trying to figure out how to build the argument, because they're seeing so much success with it on the street. So I was just curious if anybody else is using 2s, is, generally their thoughts on that.
Yeah, you bring up a good point. And like, I know the Narcan that we have is going to be 4 milligrams, right? I don't know what our emergency responders are using, but I do know the instances that the folks on the team I was on did need more than one administration of whichever dosage that our EMS was using. Yeah, but
I mean, they're still using the 4s occasionally. And if people respond before our EMT techs come, and this is only between 7 p.m. and 7 a.m. And it's just kind of, they've just been doing it and realizing that it works. So they keep doing it, and they haven't been needing the 4s. They're finding that just oxygen and immediate attention has been really successful. I mean, I'm sure like if if it's not working, nobody's gonna not give, 2 milligram, more 2 milligrams or 4 milligrams. But it's one of those things where it's like, we need the data to make the argument to do the thing to get more money. So we're just in those preliminary stages.
Thanks for sharing that, Layla. It sounds like it was really helpful for other people as well. Any last minute questions or ideas that you heard today that you're interested in trying at your agency, or talking about with colleagues, ideas about exploring around new harm reduction strategies? Well, we dropped the link to the evaluation in the chat. As usual, we will follow up with an email with your slides, your tip sheets, etc. And then we'll look forward to seeing you all again next week. Next week, we're going to talk a lot more about all of those different tools that we use in conversation with participants, the overdose prevention plan, the safety plan, the honest budget, the readiness ruler we'll talk a little bit more about, the continuum of use, etc. So thanks, everyone.